Friends, aspirin we have been using not for decades, but for centuries now. And it is time that we rethink about how and when we use aspirin, and more importantly, how and when we should not be using. So dogmas came into the picture. Aspirin a day keeps a cardiologist away. Just take an aspirin and avoid a visit to emergency room. Aspirin is better than intervention. So this were the kind of dogmas which are there not only in clinicians' mind but also in patients' mind. And hell, lot of people used to take aspirin to prevent heart attack even without medical advice, because of the kind of confidence, easy availability. Friends, aspirin we have been using not for decades but for centuries now. And it is time that we rethink about how and when we use aspirin, and more importantly, how and when we should not be using. So the slides are not too many. We'll have a lot of time for discussion. So, friends, let's go to the history. Aspirin has been in use in its natural form for thousands of years. Ancient civilizations were using below bark, which is the source of aspirin. 400 BC, which is almost 3,000 years from today, and it was being used for pain relief, particularly during childbirth. But the real aspirin history starts from 1897. Barsha, can you see the mouse cursor over this?
No, sir.
All right. Okay. So 1980s, 1987, the aspirin was synthesized, not from the natural sources. And in 1899, so almost 125 years back, Bayer's patented the aspirin all over the world. Made a huge amount of money out of this. Between 1950, so almost 50 years after it was patented, its pain relief, anti-inflammatory, and heart disease prevention properties were, discovered, reconfirmed, etc. In 1982 was the Nobel Prize winning discovery of aspirin's mechanism of action. Just see, from 1897 to 1982, almost 90 years it took to understand what is the mechanism of aspirin. It is prostaglandin inhibitors. In 1974, there was the first randomized trial, almost 10-15 years post understanding its mechanism of action, that the first randomized trial on myocardial infarction was done. 1980, it was approved in stroke. 1985, it was approved in myocardial infarction. So it's a very checkered and a very long history. And since for decades before it got approved for myocardial infarction or stroke, so-called secondary prevention of ASCVD, it was almost an over-the-counter medicine for pain relief. People had so much of faith in it. Unlike the statins, we still have a lot of statin naysayers, but blood thinner if you give, they don't mind taking. Exactly the opposite of what they should be worried about. They should not be worried about statin related side effects, and they should be worried about aspirin related side effect. But for over the years, when it was used for just for a few days for any fever or headache or body aches, etc., people had developed kind of confidence in this, and that's why a lot of dogmas came into the picture. Aspirin a day keeps a cardiologist away. Just take an aspirin and avoid a visit to emergency room. Aspirin is better than intervention. So this were the kind of dogmas which are there not only in clinicians' mind but also in patients' mind. And hell, lot of people used to take aspirin to prevent heart attack, even without medical advice, because of the kind of confidence, easy availability, and over-the-counter status of this particular molecule. What was the result? Millions of people worldwide were taking aspirin. Almost 40% of US population, as per the estimation in 2007, over the age of 40 were consuming aspirin. Almost 50% of the people above the age of 60, even in 2021, were taking aspirin. And one more analysis was done, that what about low risk individuals, people who do not have very high risk. In the people who were classified as low risk, 25% of low risk patients were taking aspirin to prevent ASCVD. Now, in next couple of slides, we are going to come to know that this is not only not helpful, but it is significantly harmful to take aspirin in low risk patients for primary prevention. So let us start our journey into this. This is just the one page of pictures I got of aspirin advertisement. There were at least half a dozen picture or screen full of advertisements by Bayer for aspirin. So now there is no wonder, and this was going on from something like 1980s onwards, and it's no wonder that people had developed so much of confidence and faith in aspirin. So let's have just a short understanding of what's primary prevention and what is secondary prevention. I'm sure all of the clinicians know about it. What I wanted to emphasize, primary prevention by definition is before the occurrence of disease, in this particular scenario, atherosclerotic cardiovascular disease, while secondary prevention is after it has occurred, not only after the clinical event like infarct, stroke, or gangrene, but even after an asymptomatic plaques are being detected. Say you do a carotid Doppler or carotid intima media thickness, and you find that there are plaques, or you do a CT coronary angiography just for as a preventive checkup, and you find some plaques there. That patient would classify as secondary prevention. The primary prevention cohort or the population is primarily is a very low risk. The risk ranges from something like low risk, which falls into less than 5%, or intermediate risk, borderline risk between 5 to 15%, 10-year risk of ASCVD, and above 15-20% is classified as a high risk ASCVD, above 15 to 20% probability of incidence of coronary events, cerebral events, peripheral vascular events, sudden cardiac death. And primary prevention population is much, much larger than the secondary prevention population. So even a small percentage of side effect in primary prevention population, since they are going to the number of population which is going to be exposed to a very large extent, the absolute number of side effects may be very, very, very high. Just take an example of Giloy, which was offered by Ministry of Health in India to prevent COVID. Just imagine, out of 140 crore people, if even 10 crore people start taking Giloy, and if 1,000 people develop the kind of fulminant hepatic failure leading to death, and Giloy, which has got a questionable benefit in preventing or managing COVID, just imagine the kind of damage you would be giving to the population. So this is an excellent example of a very bad primary preventive strategy for COVID. And similar kind of situation is happening with aspirin. So one must be absolutely sure about your math when you are offering primary prevention. What is the relative benefit? What is the absolute benefit? And what is the net clinical benefit? Secondary prevention population is relatively smaller. Their baseline risk is very high, and absolute risk reduction could be on a higher side, and hence a small incidence of side effect will be overshadowed by the large number of events prevented, and net clinical benefit is likely to be large in secondary prevention. So that brings us, let us understand how the statistics is being presented to us in large number of pharma sponsored CMEs and events, is the absolute versus relative risk reduction. Take any trial, not only cardiovascular, take diabetes, take dyslipidemia, anyone. Relative percentage is relatively constant. Like, say, for example, you do a 25% reduction in your LDL levels, you'll have a 25% reduction in your ASCVD risk. So relative percentage is constant, but the absolute benefit varies depending upon your baseline risk. You have a higher baseline risk, your absolute benefit is more. You have a lower baseline risk, you have a lower absolute risk. I'm going to explain you that in next slide. And side effects are relatively constant. Let's say aspirin side effect is something like 6 to 10% risk of bleeding, major bleeding over 10 years. That is constant irrespective of whether you are treating low risk population or a high risk population. So net clinical benefit, which is the absolute benefit minus absolute risk, is going to be low in people who are in low risk category, and primary prevention people are obviously in low risk category. So let's example. For example, you take statin. If you take statin, the percentage risk reduction is compared to the control group. So if the baseline risk, heart attack risk is 10%, and they reduce the risk to 5%, 50% risk reduction with 50% reduction in the LDL values. So relative risk reduction here is 50%, but the absolute risk reduction is 5%. You treat 100 people for the trial duration, risk reduction is 50%. You are preventing 5 major adverse cardiovascular events, and that is in a population where the risk was 10%. Now you take a people whose whose baseline risk is, say, 50%, then your absolute risk reduction will be 25%. 50% of 50 will be 25%. And now you take a low risk population, say population where the baseline risk is just 5%. On 5%, when you get a 50% risk reduction using statin, your absolute benefit is just 2.5%. Now that is with statin, and statin side effects are not even 2.5%. The major serious life-threatening side effect I am talking about, not talking about the simple plain myalgias. And now you shift this calculation to aspirin. In aspirin, there is a modest risk reduction. Relative risk reduction is 15 to 20%. Even that is questioned by a modern trials, but let's presume that aspirin causes 15 to 20% risk reduction in ASCVD. If you, in a very low risk patient, aspirin prevents only one heart attack plus 10,000 people, but it's going to cause 21 major bleeds. So net clinical benefit is not there. On the contrary, out of 10,000 people, you are giving a net clinical harm to 20 patients. Even in high risk patient, aspirin is going to prevent 49 heart attacks per 10,000 patients. But in those high risk patients, because they fall into high risk bleed category 2, you are going to cause 98 major bleeds. That is the reason why with aspirin, the math does not justify the use of aspirin in low to intermediate risk primary prevention patients. The rationale for primary prevention was with COX-1 inhibition, prostaglandin synthesis inhibition, reduction in thromboxane A2, there is a thrombosis which is being prevented. And thrombosis is the inciting mechanism for unstable angina, non-QI infarction, QI infarction, or ischemic stroke. But studies have suggested that the risk of thrombosis is intermittent, once maybe in a few months or year, only at the time of the event. And only for covering that, if you are keeping the patient anticoagulated for a long time, does it really make sense? And does that sense prevail even in the modern era of statins, antihypertensive treatment, dyslipidemia treatment, that needs to be seen. Now let's see what were the primary prevention trial. First of all, we did not have very robust double-blind randomized controlled trials for primary prevention. We did have some cohorts like physicians health study, women's health study, hot trial, and PPP trial, all in 1980 to 2000 range. In male physicians, female health professionals, even in so-called moderate risk patients like only hypertensive patients or patients with more than CVD risk factors, more than one CVD risk factors, which would be falling into moderate risk patients. The key efficacy parameter, major bleeding, the primary efficacy was myocardial infarction, stroke, etc. The key efficacy parameter, majority of trials did not reach the statistical significance. Only in physicians health study you can see relative risk reduction was 44% and hazard ratio was statistically significant. All other were crossing 1. First of all, risk reduction was only modest, 9%, 15%, 10%, and they were approaching 1, so statistically not significant. But major bleeding, if you see, 24% increase, 54% increase, 37% increase, a huge rate increase in the risk of bleeding. So majority of trials, either reduction in non-fatal MI, which is modest, no effect on cardiovascular mortality or all-cause mortality. In fact, there was a non-statistical, non-significant increase in risk of stroke in physicians' health study. Rest of the population, there was no reduction in major CV events, not even all-cause mortality. Sometimes significant increase in the incidence of stroke. And when the stroke occurred, chances of conversion to hemorrhagic stroke was on higher side. Very unfortunately, the lower part animation is not working over here, but in the lower part what we have is 3 modern trials of aspirin in primary prevention. Okay, those 3 modern trials were Arrive, Ascend, and Aspirin, as we can see over here. All these trials clearly showed that there was no significant reduction in myocardial infarction, stroke, all-cause mortality, or nor there was any reduction in cardiovascular mortality. There was a significant increase in the risk of bleeding. There was some hypothesis that yes, if CVD doesn't come down, at least cancer comes down. All these 3 large trials involving large number of patients, 6,000, 7,000, 9,000 patients, randomized double-blind control trials, and there was no significant effect on the cancer risk. In fact, in Aspirin trial, there was an increased risk of malignancy also. So consistently, the modern trials done in recent times did not show any benefit, definite harm in terms of bleeding, and sometimes even increase in the risk of stroke. So these trials were the real death nail for the use of aspirin in primary prevention, particularly in low risk to moderate risk population. This is the same slide being repeated. Even the data analysis was done for different ethnicities: Caucasians, Black, Hispanic, Asians, Native Americans. None of them they reduced CV mortality. None of them they reduced MACE. You can see the hazard ratio, the upper limit goes beyond 1. So no statistically significant benefit was seen in primary prevention. This was the vital cohort. It's not a double-blind randomized trial. It's a cohort prospective study of vitamin and other things. So the previous trials or cohort showed some modest benefit, and modern trials, recent, just a decade and a half back, it did not show any benefit. What changed between the two? What has changed is the patient's baseline risk has changed. With the availability of hypertension and better hypertension treatment, ASCVD incidence has come down. With the use of statins, and targeting LDL more and more aggressively, the baseline risk has significantly come down. Better management of diabetes with the molecules which reduce diabetic complications as well as ASCVD, like GLP-1 and SGLT2 inhibitors, they have reduced the baseline risk. So a person who has a very high baseline risk of 20% risk of ASCVD in next 10 years as per the prevent risk calculator or ASCVD risk calculator or a QRIS3 calculator. Now you give them statin, 50% reduction falls to 10%. He is managed with hypertension, his diabetes is managed, he is on GLP-1. I believe the risk will drop down to 5%. So somebody who has a 5% risk of next 10 years, you give aspirin with 6 to 10% risk of bleeding, the math does not, it does not match at all. And then we are talking about the use of primary angioplasty, better stent designs, better platforms using intravascular imaging. We have a much better results even in patients who come with acute coronary syndrome, and hence even in secondary prevention we are talking about de-escalating the intensity of antiplatelet therapy. So this reduction in the baseline risk has again contributed to reduced baseline risk, and hence the modern trials, Aspirin, Aspire, etc., have been negative. So to summarize about the primary prevention, friends, decades of recommendation to give aspirin for primary prevention of CV events was based on over optimistic interpretation of inconclusive data, which have very markedly reduced relevance in current era of stronger and safer preventive strategies of hypertension, lipids, diabetes, etc. It was overturned after the randomized clinical trial with approximately 1 lakh person years of follow-up. And in that, it was shown in that randomized clinical trial that aspirin increased all-cause mortality, probably contributed by some increase in cancer, some increase in intracranial hemorrhage, some increase in the hemorrhagic stroke, etc. Several other primary prevention trials of aspirin also showed that benefit was not there. And in a patient who were undergoing orthopedic surgery, 17,000 patients, it was shown to increase myocardial infarction on aspirin 160 milligram per day. So currently, the recommendation for primary prevention aspirin use is largely reversed. Mild to moderate risk you don't give. Even in high risk, the recommendations are only grade 2B. It may be given. So that is based on Arrive, Ascend, and Aspire trial. It is better to focus on lifestyle modification, statins, antihypertensive therapy, and better management of your diabetes. If you see guidelines of 1990s, US Preventive Service Task Force, it recommended low dose aspirin for patients who are at increased cardiovascular disease, but they did not define whether increased risk was mildly increased, moderately increased, or severely increased. AHA said that men over the age of 40 and women over the age of 50, when the risk really starts, one should take in account the possibility of GI bleed. So cautious indication was there, and similar kind of indications were there elsewhere. European Society did not recommend use it in primary prevention. Guidelines just a decade ago, US Preventive Task Force recommendation from 2016. People between 50 to 70 with a 10-year ASCVD risk of more than 10%, you may use it. ADA said that men and women above the age of 50 with diabetes and higher ASCVD risk, you may consider. The level of evidence or the strength of recommendation was 2B, not class 1A, not class 2, class 2A, 2B. European Society again did not recommend, and the current guidelines. What are the current guidelines? Current guidelines, US Preventive Services Task Force 2022, between 40 to 59, ASCVD risk more than 10% over 10 years, only if they are not at increased risk of bleeding, and that has to be a shared decision making. Give the option to the patient. People above the age of 60, do not give. Class 3 indication, harm. Low to moderate risk, do not give, because the benefit does not exceed the risk of bleeding, and that's a very modest indication, class 2B. In high risk individuals, it's better to focus on other modalities of prevention, and very careful uh, calculation must be done between risk and benefit analysis, and alternative strategies are a better focus, better returns on those preventive these things. One small comment I came across: in a special situation like somebody who has a lipoprotein A, LP little a, which is genetically determined, and their LP little a mimics it increases not only the atherogenic risk but the thrombotic risk too. And these are the group of patients where we do not have much of preventive strategies available. Post hoc analysis of two primary prevention trials showed a significant benefit in the subgroup of patients with high LP little a. It's a hypothesis generating. It's not a strong recommendation, but as of now, you can extrapolate your knowledge, and people with very high LP little a and a strong family history, maybe you can recommend. This is probably the only risk group which I could think that in primary prevention I might be using aspirin, but we do need randomized control trials. And the lucky part is there are a couple of new molecules which are in the pipeline for LP little a, and now there will be a lot of heightened interest from the industry, from the pharma industry, and probably we'll have more and more data which we will be able to use for our patients. So far we were using aspirin in primary prevention purely from the peer pressure, concerns about litigation, even if there were a lot of doubts about its utility. And some people argue that aspirin should not be used for chronic ASCVD because the evidence is ineffective and inconclusive. But where is the evidence that it does not act? So this kind of skewed kind of arguments were being used. But now with the current guidelines, current data, current these things, I think aspirin has very reduced role in very high risk patients, or maybe in patients who are a high risk of or in this special population. Now let's focus on secondary prevention. Primary prevention, the case is rested. No use in low risk, no use in moderate risk, use in high risk based on patient preferences after having a careful discussion with the patient, mentioning him what is likely to be the absolute benefit and what is the likelihood of the absolute risk. Now, this is the paper published in 2024, and now we have started questioning the dogma of the use of aspirin even in secondary prevention, particularly the long-term use of aspirin after ASCVD diagnosis in chronic stable patients, after acute events like acute coronary syndrome, or after PCI or CABG. And here again, we have a pseudoscience. We have been using dual antiplatelet for almost 1 year after myocardial infarction, angioplasty, or a bypass surgery. And we are using at least a single antiplatelet, dominantly aspirin, for lifelong in patients who have. Is this a science or a pseudoscience? That's a big question. There is not a single trial which provides conclusive evidence that long-term administration of aspirin improves outcome in patients with chronic stable ASCVD. The belief in aspirin in this indication is based on flawed meta-analysis. Meta-analysis are not a strong proof. They are useful for confirming that what was shown in relevant trials is shown across different population, different trials, different countries, different ethnicities. But if the meta-analysis is based on multiple small inconclusive trials, the results are not going to be robust, can be followed. At best, they can be hypothesis generating, and it could be the basis of new trials. It's again the peer pressure, fear of litigation, etc., that we keep using long term in patients with patients with existing coronary artery disease. It's said that the plaque rupture occurs once in a few months or a year. You can't keep on giving them uh, antiplatelets which have a continuous risk every day you take it for an event which is going to be occurring once in a while, and the event which can be prevented by lifestyle, prevented by statins very significantly. Nowadays we can reduce your LDL levels to almost 80, 85, 90% with the combination dyslipidemia therapy, say high intensity potent statin, bempedoic acid, ezetimibe, PCSK9 inhibitor, or small interfering RNA therapy like inclisiran. With all those things combined together, and when you put GLP-1, which again reduce the risk, when you put glitazones like pioglitazone, etc., again they reduce the risk. Do we really need to continuously keep the platelets suppressed, which are vital for preventing hemorrhage? So let us see what science we have and what people have started thinking. The rational or irrational was that the thrombosis is the primary mechanism for underlying vascular events, and if you prevent thrombosis, it's going to be prevented. Now, it's not always the plaque rupture or erosion which creates an acute event. It could be the spontaneous coronary artery dissection. The medial fibers are defective, and that start dissecting, and an intraplaque hemorrhage occurs. Intraplaque hemorrhage because of either defect in connective tissue or defective small vessels which are supplying the arterial wall, vasa vasorum. The intraplaque hemorrhage will swell the endothelium, and then ultimately it may rupture into the vascular tree, and that could be the mechanism in a significant number of patients. And if that is the mechanism, aspirin is not only not likely to be helpful, but it could be harmful. And once, even if the plaque has ruptured, it has healed over next few months time. Do we really need very strong antiplatelets or any antiplatelets at all? These are the questions being raised. Since aspirin and older generation of statin left a lot of residual risk, we never thought of a trial of no antiplatelet therapy. We always compared aspirin with aspirin plus clopidogrel, aspirin with aspirin plus ticagrelor, aspirin with aspirin plus prasugrel, but we never thought of reducing the intensity. And by convention, 12 months was the duration, so all the trials were conducted for 12 months, and 12 months minimum dual antiplatelet therapy is something which was recommended. So much is the fate that the last patient which I saw half an hour, 1 hour back in my clinic had an angioplasty in 2015. Up to 2020, he was seeing a cardiologist and he was on aspirin plus clopidogrel. After 2020, he has not seen anybody and he is on dual antiplatelet now. So over 10 years, he has had an increased risk of bleeding because of aspirin over 10 years, and dual antiplatelet, the risk would be much more, maybe 20-25%. Luckily, he did not have any incidence of hemorrhage, and his cataract was a blessing in disguise, which brought him to me, and probably I'm going to de-escalate his therapy. So now, since the pathological substrate of the understyle vascular occlusion, the plaque itself has evolved, it is becoming more stable, less inflamed, with a thicker cap. Do we really need antiplatelet therapy or high intensity antiplatelet therapy for long is a big question. The trials of secondary prevention, there are only two substantial placebo-controlled trials of aspirin in patients with chronic ASCVD. One was AIMS trial, 4,500 patients, and they were randomized to 1,000 milligram aspirin. CV events were not reduced over the following 3 years, and there was a trend to increased mortality, especially in women. So modest, questionable benefit or even a hint of risk. The authors therein concluded that aspirin is not recommended for routine use in patients who have survived an MI. Maybe a dose was too high, but the use is questionable. The Swedish angina pectoris aspirin trial, support trial, 2035 patients, aspirin was used in lower dose. Uh, but the patients were selected, ASCVD patients were selected based on clinical description of angina. No stress test, no nuclear studies, no imaging studies, no angiography. Median follow of 50 months, 5 fewer MIs per 1000 patient year follow up in those who are assigned to aspirin. Now, the incidence of bleeding would be something like 6 to 10 or even more. So, practically no benefit shown even in this group of patients. Uh, So they say that high intensity antiplatelet therapy is required only when the iron is hot, only when your plaque has ruptured and it has still not stabilized. The lasting benefit can be delivered by short term intervention given at the right time. So when patient is at higher risk of ACS, you give them. The ISIS-2 international study of infarct survival published 1998 randomized 7,000 plus patients, aspirin 165 milligram or placebo, and after which the aspirin was stopped. There was no reason to initiate aspirin due to lack of evidence after that. Those randomized to aspirin had similar reduction in mortality at both 35 days and 10 years. So even after you stop it for after 28 days, at 10 years mortalities were similar as compared to the placebo group, even if you did not take it for 10 years. US Veteran Administration trial, unstable angina, similar results were shown. After 3 months, mortality was slightly lower with aspirin 325 milligram per day, but 9 months after stopping aspirin, the reduction in mortality was same. There was no significant difference. So after the iron has cooled down, there is no point in continuing the antiplatelet therapy based on these trials. So it justifies the shorter course. So though the science is based on evidence, but evidence, how it is collected, in which era is collected, in which surroundings it's collected, it's important. And repeatedly we need to question ourselves that what we decided couple of decades back, does it still hold true in the modern era? The edifice of aspirin trials in chronic ASCVD had no solid foundation. It is built on shifting sands, and because it is built on shifting sands, it has started to crumble. 40 years ago, dogma dictated that ventricular ectopy, this is one of the classical example where science need to question itself. We knew that ventricular ectopy, when it is more than certain numbers per hour or per day, there is an increased risk of mortality, particularly sudden cardiac death, because of VTAC, VFib, established fact. Class 1 antiarrhythmic agents like flecainide, encainide, when you use, there is a 90% reduction, prolonged, repeated, halter proven 90% reduction in the incidence of VPCs. So, in the wishful thinking, it was used routinely. But when the hypothesis was questioned in the cardiac arrhythmia suppression trial, it was found that in patients with VPC, when you give flecainide, encainide, there was a 250% increase in mortality. These were class 1 agents, and 250% increase in mortality. And that point onwards, largely it was focused on people with defective hearts, structural abnormality in the ventricle, etc. But this is a classical eye-opening example that every hypothesis, every dogma needs to be questioned. For many years, second example is lifelong administration of beta blockers was recommended after myocardial infarction, but the recent randomized trials of withholding or withdrawing beta blockers after MI, particularly 2 years after MI, clearly casts a doubt because there is no benefit of beta blocker continuing beyond that. Similarly, we need to question our dogma about aspirin even in secondary prevention. So we think of de-escalation in acute coronary syndrome after PCI. For 12 months, it was established that dual antiplatelet you use, and as more and more agents started coming stronger and better and more consistent antiplatelet agents like ticagrelor and prasugrel, we started giving them for 12 months. But then we started seeing bleeding, and we started evaluating de-escalation therapy, that instead of 12 months, can we stop at 6 months? Yes, we had enough number of strong, well-designed trials which show that at 6 months, if you stop, there is no increase in cardiovascular events, and there is a distinct reduction in bleeding. The current trials have gone down up to 3 months. After 3 months, you can stop one antiplatelet agent. And looking at the data of aspirin, which is the single most important or a more potent inducer of bleeding, particularly in GI tract, aspirin is the one which should be stopped. In fact, there are enough number of trials wherein after 1 month of angioplasty, even if it is a complex left main bifurcation, multiple stents, overlapping stents, there is no increased incidence of stent thrombosis. Why? Because we have a stronger antiplatelet agents which are more consistent. Aspirin has got an aspirin resistance possibility, while clopidogrel has less resistance. Ticagrelor and prasugrel have practically no resistance. Their metabolism is more simple, straightforward. There are less drug interactions. So even after 1 month in complex high-risk angioplasty, if you stop, particularly in high bleeding risk patients, there is no harm done. In fact, I came across a cohort, not double-blind randomized control trial, wherein after 1 day, aspirin was stopped. Aspirin was given just before the procedure, 325 milligram, single dose, not to be repeated after 1 day of angioplasty, and there was no early indication of any adverse events because of stopping aspirin after 1 day. Of course, this is not the gospel truth. We need to confirm it in double-blind randomized control trials. But as of now, based on the trials which are available, if you stop aspirin after 3 months, there is no harm, and that is my routine practice for last couple of years. So switch down to single antiplatelet therapy. Now the expert opinions and editorials have started coming that why not start a trial of no antiplatelet therapy after 1.5 months or 2 months of ACS or PCI, because the newer, stronger statins and lipid lowering therapies are taking care of the plaques. Plaque rupture chances are really, really less. If you can't start something, then you start with a lower intensity, say twice a week antiplatelet or once a week long acting antiplatelet. And in the de-escalation therapy, we are also thinking of, instead of aspirin, use clopidogrel in the long run. You have given 3 months dual antiplatelet, or 12 months if you are believing in 12 months. After 12 months, what? Aspirin or clopidogrel? Even there, we have good data. Clopidogrel or aspirin in monotherapy long term after ACS or PCI. 133,000 patients. This is a Korean data. Clopidogrel monotherapy reduced the MACE 2.8 versus 4.1 absolute risk of MACE. So clopidogrel had a lower incidence of MACE, a shade lower incidence of bleeding, 2.1 versus 2.4%. So overall, net clinically, clopidogrel outperformed aspirin in reducing CV events that had a lower bleeding risk. Smart Choice 3 was a double-blind randomized controlled trial, 5,500 patient, clopidogrel versus aspirin. Clopidogrel group had a lower all-cause mortality. Now, all-cause mortality is a very hard clinical endpoint. Lower risk of myocardial infarction, lower risk of lower risk of bleeding, and thus there was a superior net clinical benefit and long-term secondary prevention. So clinical recommendation now is that clopidogrel is preferred over aspirin for secondary patients who 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 do not need dual antiplatelet therapy, or who cannot complete dual antiplatelet therapy for some reason. So somebody develops a stroke, intracerebral hemorrhage, GI bleed. You have stopped DAPT. You cannot give DAPT now. SAPT has to be given. It's better to give clopidogrel. Those who have a higher risk and lower risk of bleeding, only in those patients you might continue a little longer DAPT therapy. And that is what the tendency is now. So, is that being reflected in the practice? In 1995, right side, you can see most widely used drug, aspirin, was on the top. While in 2025, most widely used drugs, you do not find aspirin in one of the top 10. So that is the impact which is there. Unfortunately, these concepts have not percolated everywhere, and that was the reason why I selected this topic. And as it is said, where religion ends, philosophy begins. Where alchemy ends, the chemistry begins. Where astrology ends, astronomy begins. And where dogmas and fashion and peer pressure and fear of legal litigation ends, the evidence based medicine begins. We have a huge amount of evidence percolating. And probably the aspirin use need to go down very drastically. The only use of aspirin I can think of in this situation, and husband went to his bedroom, and he brought two tablets of aspirin and a glass of water for his wife. His wife asked, "Why are you giving me aspirin?" He said, "It's for headache." The wife said, "What headache? I don't have headache." Husband said, "That's what. Now I got you. I hope you understand." And believe me, this was the advertisement given by Bayer almost 100 years, almost 50, 60 years back. And those days itself, probably they knew, if you can see the batter at the bottom, that it does not affect the heart. So 40, 50 years back, when Bayer was advertising, hundreds of advertisements were there. That time they said it does not affect the heart. And today, that prophecy has come true. Aspirin does not affect the heart. And now, friends, last slide. Knowledge is sharing. I love to share my knowledge. I hope you have liked those today's presentation. If you have any question, comments, concerns, or if you want to share your experience or your views, you are most welcome. My last lecture 2 months back was on extremely low LDL, a very important concept. If you have missed that, you can go on to the Medflix site, it is there. And I would also love to have suggestions from you. What could be the next topic which you would like to hear? A few of my thoughts are ASCVD risk calculators. We can exactly define what is the risk in patients for primary prevention, which calculator to use, what are the pros and cons, which not to use. That is one topic I can think of. Coronary calcium score is being done, every Tom, Dick, and Harry, even laymen are going to the CT scan centers and asking for CT calcium score. What is its significance? Where it is to be used? Where it is not to be used? What is the interpretation of that? That's another important topic. Lipoprotein A is coming out as a very big molecule for the residual risk. Large number of people have lipoprotein A, which is elevated, almost 20% of the world's population, and they could be responsible for the residual risk despite doing all antiplatelet therapies, interventions like angioplasty or bypass surgery, statins, PCSK9 inhibitor, etc. So, and three molecules are almost on the verge of being approved for clinical these things. Phase 3 trials are in the last phases. So these are three topics I can think of, but any topic which you find is interesting, you feel free to write to me. In the last slide, my WhatsApp and email numbers are there. You can put your questions today. You can send them to me on WhatsApp or email, or on Medflix sites. There are question comments once in a week or so. I log into it, and if there are any questions, I would try to answer that. Thank you very much for your attention, friends. And now I will hand over the session to Barsha for any question, comment, suggestion.
Thank you so much, sir, for that wonderful session. We'll just keep this screen on for a minute so that the doctors can note down your contact details.
Sure.
So there's a lot of questions that are coming in. We will be getting into that now. So, doctors, getting started with the Q&A. One of the earlier questions that we had, it is highlighted on the screen, sir. So Dr. Das is asking, does it cause bronchoconstriction?
Uh, Theoretically, yes, it can cause bronchoconstriction. Those bronchoconstrictions are not really severe. I have not seen many bronchoconstrictions occurring with aspirin, but yes, aspirin reaction in terms of bronchoconstriction, hemorrhage, of course, everybody knows about it. But in people who are predisposed to asthma, bronchoconstriction is a clear possibility. But if somebody develops an bronchoconstrictions, I a couple of years back I used to change them at a drop of head from aspirin to clopidogrel. Nowadays, last few years, I don't give aspirin for a long term. I just continue as clopidogrel. Aspirin is the first one to be knocked off. It's only given for a couple of months, maybe 3 months as of now. I have not switched to 1 month therapy post ACS or post PCI.
So the next question on your screen, Dr. Kulkarni is asking, since we talked about it, how many number of patients had fulminant hepatic failure during COVID?
Fulminant hepatic failure, me being a cardiologist, I had only treated maybe 200, 250 patients, majority of them online. I did not see any fulminant hepatic failure. But there were significant number of people. Fortunately, the Giloy recommendation by Ministry of Health did not last long, and IMA and medical community had written to them to withdraw that recommendation. But there are n number of reports being published fulminant hepatic failure because of Giloy. I have not seen any.
So the next question, Dr. Das is asking, does statins increase diabetes?
Yes, it is a proven fact that statins do increase the incidence of new onset diabetes, and in patients who are diabetic, maybe 5-10% worsening of their diabetes control. The exact proven mechanism is not known. It occurs with practically all statins. The, the statistically almost 10% of new onset diabetes you can expect if you are treating hundreds of patients. Majority of them are in patients who were already predisposed to develop diabetes, like somebody who had both parents who had diabetes, or patients who are pre-diabetic, or patients who had obesity and bad lifestyle. In my opinion, if you follow with the same type of, say, 10,000 patients on statin you follow, and 10,000 patients on placebo you follow, I don't think it will be more than 3 or 4%. But yes, it does increase diabetes. The more important question is, if the statin is increasing diabetes, diabetes is a heart disease equivalent, should you give statin to people who are pre-diabetic if there are statin indication? The answer is strong yes, you must give, because despite inducing diabetes in 10% of patients, even in those 10% of patients, the ASCVD risk comes down, the plaques can regress, and the events come down, and the survival improves. So the primary benefit of preventing cardiovascular events does happen to a similar extent to the patients who also develop diabetes because of statin. So yes, 10% of them, they will develop diabetes. Some of their diabetes is going to go a little haywire. You don't have to worry about. We have n number of anti-diabetics. You step up your diabetic regime, and that sugar will be controlled.
So next, Dr. Mittal is asking, is aspirin helpful in reversible cerebral ischemic stroke with no neurological deficit? And for how long can it be given to prevent further ischemic stroke?
For an acute ischemic stroke or TIA, yes, antiplatelet is required. That is a time when a plaque has ruptured or it has got eroded and the thrombotic risk is the highest. That is the time when you are going to have the best benefit. Currently, in acute ischemic stroke, they say that dual antiplatelet, you give it for at least a month's time, and then you switch over to single antiplatelet therapy. And single antiplatelet therapy can be either aspirin or clopidogrel in the standard dose. What was the second part of the question?
Should I move on to the next question, sir?
Yeah, you can move on to next question.
So Dr. Madhav is asking, what alternatives do you suggest in primary prevention?
Primary prevention, the best is lifestyle, and the lifestyle can start right from the age of 2. In high risk patients, you can start statins right from the age of 8, like somebody who's a familial dyslipidemia, which is statin responsive, right from the age of 10. American Pediatric Association says that from the age of 8 or 10, you can start the statin therapy. Lifestyle is the best. If you've heard about Dr. Eugene Braunwald, Braunwald's heart disease, the Hearst, which is supposed to be a cardiologist's Bible. Eugene Braunwald is approaching 100. I'm sure it must be 96 or 98 now. He recently published an article that if you want to live till 100, throughout your life, you keep your LDL below 100. So, first is lifestyle. Second is have a check of your lipid profile from early teens, maybe 10, 15 years of age, and keep your LDL below 100. Third thing, which is not under your control, is lipoprotein A, LP little a, which has been my suggestion for the next talk. LP little a is something which is not going to be affected by lifestyle. 20% of the world's population have it increased, and that needs to be checked once in a life. So that should be checked once in a life. It need not be checked repeatedly unless you have given them therapy for reducing LP little a. Now, what is the therapy for LP little a as of today? None. We don't have. PCSK9 gives rise to some modest reduction. Niacin was there, which is not available, again, very modest and inconsistent reduction. So, in those group of patients, you can go for a very aggressive lifestyle reduction and aggressive LDL reduction. Third thing is, if you are falling into a high risk category, do calculate your future ASCVD risk. Calculators currently available start from the age of 40 majority. Some of them they start from the age of 30. If you are falling into a high risk, lifetime risk of ASCVD also can be calculated. 10-year risk also can be calculated. If you are falling anything above 7.5%, my recommendation is lifestyle plus statin. If lifestyle has failed, of course statin, and bring down your LDL to the recommended level depending upon situation which are there. There are certain situations where irrespective of age, irrespective of anything else, you need to give them the statin, which is familial hypercholesterolemia, or anybody whose LDL is above 190, even at the age of 10, 15, 20, they need to have statins.
Next, Dr. Mayuresh is asking, hyperhomocystinemia with high risk, is there any indication?
Hyperhomocystinemia is more of a thrombotic risk. Unfortunately, we do not have very strong data, and hyperhomocystinemia can be very easily managed by group of vitamins B1, B6, B12, and I think that is the best you can do. In those patients, you go for the LDL at a lower level rather than LDL target of 100. You go to 70, and your risk will be prevented, and you give medicines to prevent to reduce the homocysteine levels. But I would not really recommend aspirin in patients with elevated homocysteine levels.
Uh, Disprin to 325 mg in primary prevention, so the role.
It,
Dr. Radha is
it has
asking.
been amply proven that anything above 75 or 100 milligram has no additional benefit, and on top of that, it is harmful. So 325 milligram has practically no role except at the time of loading when the patient was not on aspirin, or when you are using it for rheumatic fever or inflammatory conditions, etc.
So Dr. Munawar wants to know the role of aspirin in pregnancy, like how far is it beneficial?
In pregnancy, aspirin, when indicated, it should be given. There is no harmful effect on the fetus, and it has been indicated in prevention of preeclampsia and eclampsia in pregnant ladies who are at an increased risk. So, aspirin is safely given by us and the gynecologist. We do have, in last 35 years of my practice, a couple of patients during pregnancy. We have managed them acute coronary syndrome. We have done primary angioplasty, etc. And aspirin can be safely given.
So there was another question from Dr. Mittal. Is aspirin in low dose safe in patients suffering from autoimmune primary biliary cholangitis with recent cerebral ischemic stroke, thrombolyzed for secondary prevention?
Primary biliary cirrhosis, I'm not really aware about the indication. Can you repeat the question?
Yeah, sir, it is highlighted on the screen. Is aspirin in low dose safe in patients suffering from autoimmune primary biliary cholangitis with recent cerebral ischemic stroke thrombolyzed for secondary prevention?
Unfortunately, I'm not aware of those things and I would like to skip the question. Maybe you can put it in the comment section in the Medflix website and I'll do my research and get back to you.
So next, Dr. Balwinder is saying that still a lot of doctors recommend aspirin in heart disease and in headache too. So why is that?
Well, for headache, there are many safer options which does not give rise to gastritis or anything. To start with paracetamol, but even if it is prescribed for a couple of days, I don't think there is a greatly increased risk of bleeding. So those who tolerate, they can take it. Uh, I for sure do not give aspirin for headache to anyone of late. Particularly when you have paracetamol, you have tramadol, we have a lot of NSAIDs which are fairly safe to use in patients who do not have any comorbidities. Couple of days of NSAIDs or aspirin is not going to cause a great harm. For primary prevention, to me, only patients with elevated LP little a or uh, practically none, because clopidogrel is better even if you decide to give for long-term primary prevention. Say you put an ASCVD risk calculator and patient's risk comes to say 30% over next 10 years. So in those patients, 6% increased risk of bleeding with aspirin is acceptable. But even there, why not use clopidogrel? Risk of bleeding is less. And why not use other preventive therapies like statins plus ezetimibe or statin plus bempedoic acid and reduce the risk down to less than 10%, where need for aspirin is practically not there. So in my opinion, primary prevention, aspirin is not needed. Of course, if you have a patient who has a 30% ASCVD risk and he has developed a serious life-threatening complication with statin, so you can't give him statin now, and bempedoic acid and ezetimibe are not effective enough. You have given him, his LDL is still 160, 170, so by calculator his risk would be more than 10%. Even in then, probably I would prefer clopidogrel.
So next, Dr. Ravi is asking the role of aspirin in lichenoid drug eruptions and erythema multiforme.
Lichen drug eruptions are one of the known side effect of aspirin. uh, I don't think if somebody who develops that, I would be giving them. They are very difficult to distinguish from idiopathic lichen planus, etc. I would rather involve dermatologists in that, and I would not give aspirin in patients who have this condition, because aspirin is one of the cause for lichenoid eruptions.
So can we take a few more questions?
I have no problems.
Yeah. Next is from Dr. Gulam. Family history of sudden death after 50. Is it possible to take primary prevention, sir?
Sudden cardiac death after 50. Yes, but most probably, sudden cardiac death is not not something which is really sudden, and it's not always ASCVD or plaque rupture which has caused it. There are many other causes like hypertrophic cardiomyopathy, like channelopathies, like variety of arrhythmias, arrhythmogenic right ventricular dysplasias, Brugada syndrome. There are lots and lots of causes for sudden cardiac death. ASCVD is the only one out of this which can be predicted and which can be prevented from the age of 20, 15, 20, 25, 30. If you had done a checkup and if you found out that you are falling into high risk, then yes, all those ASCVD risk prevention modalities which we have discussed, you can apply that and your chances of sudden cardiac death would definitely come down.
Next, Dr. Aziz is asking the uses in gastric patient.
Gastric patients, I think he believes he is asking that patients who have kind of GI disturbances in terms of acidity, gas, burning, nausea, etc. Since we have an option available which causes less gastritis, and this gastric side effects are aspirin are mediated through prostaglandins, and clopidogrel, since it works by P2Y12 inhibitors, it does not have that much gastric side effects. Even gastric bleeding is more with aspirin as compared to clopidogrel. So I would definitely switch them to clopidogrel. Any patient who has a lot of GI side effects with aspirin or even with clopidogrel, sometimes you can always give them PPIs to reduce the gastric side effects. PPIs have been proven to reduce in trials the gastric bleeding with aspirin. So if at all for any reason you have to give aspirin, you can give in with PPI. But in my personal opinion, long-term aspirin don't give. Long-term after ACS PCI don't give aspirin. Chronic ASCVD stable patients don't give aspirin. Primary prevention don't give aspirin.
Next, Dr. Ahmed is asking, in fatty liver patients, which statin would be indicated?
Fatty liver, if it is alcoholic fatty liver, I would not be really worrying about. If the fatty liver patient has reached a level of very high fibrosis, then I would be careful. Majority of fatty liver, what we classified is metabolic associated fatty liver disease, or MAFLD, which is the better nomenclature and latest nomenclature for so-called fatty liver. And fatty liver is a cardiovascular risk factor. It's not necessarily a liver risk factor. Yes, it does cause cirrhosis. Yes, over long term it does cause liver cancer. But your primary focus in run-of-the-mill or garden variety of fatty liver, what you see in your clinic when you ask for an sonography, and guy has got some feature of metabolic disease like abdominal obesity, and A1C is something like 5.9, 6.1, and things like that. His triglycerides are 250, 300, 350. All these things mean the same thing. He has a metabolic liver disease, metabolic abnormalities, and cardiovascular prevention is your focus. In those group of patients, you take care of metabolic problems. Your chemical hepatitis like marginally increased SGOT, PT, etc. are going to come down. If he is diabetic, treat him. If he is pre-diabetic, take a call whether you want to treat pre-diabetes or not. We don't have any strong recommendations. Lifestyle would be the best prevention for this. Cut down on weight. If need be, take the help of pharmacotherapy like GLP-1 agonists we have available. And now Monjero, the GLP-1 GIP agonist, tirzepatide also has been introduced in the market, albeit at a lower dose only are available, only 5 milligram is available. Those are the kind of things I would be using in patients with metabolic associated fatty liver disease. I would do his risk calculation, and if he's falling in high risk category, I would also offer him statins. Metabolic associated fatty liver related specific medicines, there are very few. Saroglitazar, sold as Belipsa or Lipaglyn, is one of the medicine which has got very good effect on this. Triglyceride per se, I would not be targeting in this kind of patients, though high triglyceride are associated with higher incidence of ASCVD. But targeting triglycerides, we have not been able to prove either with fenofibrate or saroglitazar to reduce ASCVD. So, of course, if it's associated with significant amount of fibrosis, use saroglitazar. Mild grade 1, grade 2 fatty liver disease without much of fibrosis on fibroscan, go ahead and be very aggressive about ASCVD risk reduction with lifestyle, statins, etc. And practically, there is no role for antiplatelets in patients who didn't have ASCVD in this group of patients.
So next, Dr. Veena is asking, in transient ischemic attack, does one need aspirin lifelong?
Absolutely no, not lifelong. That's for sure. As we see, after a couple of weeks or months, if the patient does not develop a stroke and TI has come down, obviously the acute phase is over. Antithrombotic treatment, antiplatelet treatment is not really required. What you need is to give them the good dose of statins, find out whether they have very tight stenosis in the carotid arteries. If they are approachable, go ahead and do an angioplasty with stenting, particularly with a very high grade carotid lesion. So statins, overall risk reduction interventions if required is best, which is recommended. I often do not remember the data, but I would suggest that maybe for a year or so, a single antiplatelet, and in my opinion, clopidogrel aspirin would have a similar efficacy. Clopidogrel would have better in terms of extrapolating whatever coronary data I have presented. But any of them should be good enough. 6 months, 1 year, more than that, I don't think it would be of really great help.
Another question from Dr. Veena was alternative to statins if patients develop myalgia.
If it is myalgia, make sure that it is because of statins, because myalgia is something which is very common. Every GP's practice you go, every day there will be a couple of patients with muscle pains and fatigue and everything they must be seeing. So, not every myalgia is statin related. In fact, in Duke University database, when they analyzed 1,500 patients with myalgia, 80% of them on reintroduction with statin, there was no myalgia. Of course, if it is myositis, muscles are tender to touch, and your CPK levels are elevated, then there is a clear muscle membrane damage is happening. In those group of patients, maybe you can think of reducing the dose of statin or giving them alternate day or changing the type of statin from atorvastatin to rosuvastatin or rosuvastatin to atorvastatin, because one is water soluble, another is fat soluble, and both have a different pathway of hepatic metabolism. So one might be tolerated and other may not be. To give your best possible effort to see that the patient can be given statin despite everything. If it cannot be given, or your CPKs are say in thousands, or the patient developed a rhabdomyolysis, large amount of your CPK went to 50,000 and creatinine went up from 1 to 1 baseline to 5, 7, 8, 10. Those are the group of patients which you can't give. Then now we have two molecules available which can be combined together. uh, Azotamide, almost 15 to 20% reduction in LDL. Bempedoic acid, again 50 to 20% reduction. Both combined together, they will not match the LDL reduction of high intensity statin, but when you combine together, you'll have something like 40-45% reduction in LDL, which will give rise to 40 to 45% reduction in ASCVD risk. If the patient can afford, inclisiran prices are dropping. PCSK9 inhibitors are still costing around 35,000 a month therapy, while inclisiran, I lastly when they have one-on-one offer, you spend around 1 lakh rupees per year therapy, and that would give rise to something like 60% reduction in LDL. Beyond 60%, if you still need to reduce and patient is not statin tolerant, I mean absolutely not statin tolerant, not just any Tom, Dick and Harry complaining of myalgia 1 or 2 days. It could just be he is recovering from some flu or malaria or something. Don't stop statin for those flimsy indication. But this kind of inclisiran costing around 12,000 rupees a month therapy, you can combine with bempedoic acid and estimab together, and you'll have something like 70-80% reduction in your LDL.
Doctors, in the interest of time, we can maybe take the last two questions.
Yeah, sure.
Next is from Dr. Dinesh, the role of aspirin in avascular necrosis.
Avascular necrosis of fever or femur, correct? Is that right? Am I audible? Once the avascular necrosis of femur has already occurred, the anti-inflammatory effects are modestly beneficial. Practically no trial data. It has got some improvement in microcirculation. It improves pain because of the reduction in inflammation and pain killing. It is used in vascular conditions like this, but its efficacy is grossly uncertain. But other treatment like use of biphosphonates, anticoagulants, surgical interventions are preferred. So rather than aspirin, it might be better to go for anticoagulants. That's what I feel.
Next, Dr. Yashwant is asking, so when do we stop aspirin prior to surgery? Is there any new guideline?
There are no new guidelines. Aspirin is a irreversible inhibitor of cyclooxygenase. So once a platelet is exposed to aspirin, it will not be contributing to clotting throughout its life. In normal, it takes something like 5 to 7 days for the aspirin efficacy to go. And that efficacy improves not because the aspirin gets cleared from the blood. Even if you clear all the aspirin by doing some kind of dialysis, and within say 2 to 3 hours, all aspirin has been sucked down from the blood, still whatever platelets are remaining, they are defunct so far as clotting function is concerned, and the recovery will be only when new platelets are formed. So it takes around 5 to 7 days for enough number of new platelets to come into the circulation. Aspirin will be gone from your body within something like 8 to 10 hours or maybe 24 hours. So 5 to 7 days is something which we recommend stopping aspirin before any major surgery. Very minor surgery like piles, hernia, pacemaker implantation, etc., does not need stoppage. If the aspirin, clopidogrel, or even dual antiplatelets are going on in a very vital phase of, say, first 1 month or 3 months after MI, then many surgeries can be done with antiplatelets, or people have done even gallbladder removal. Only surgeries which cannot be done is intracranial surgery, spinal surgery, where even a small amount of blood can play havoc. If you are on aspirin or clopidogrel, 5 days is enough. If you are on prasugrel, you need to do stop it for 7 days. Ticagrelor is a reversible inhibitor, so 3 days is more than enough for that. Now, this applies for elective surgery. In case of emergency surgery, you can give the patient platelet transfusions and go ahead and take the patient for surgery. If somebody had a, say, massive head trauma or something, he's bleeding somewhere inside the stomach, or he has been stabbed into the stomach, you don't really wait for 5 to 7 days. You give them platelet transfusion, get a hematologist on board, and go ahead and operate.
So, doctors, taking the last question for tonight. Dr. Sharma is asking the role in thrombocytopenia.
If the patient has thrombocytopenia, first of all, you reevaluate whether the patient has a strong indication for continuing antiplatelet therapy. So, if it is for primary prevention, take it off. If the patient is a chronic ASCOD patient, where again role is doubtful, benefit is very modest, take it off. If the patient is on dual antiplatelet therapy for recent ACS or PCI, 3 months have happened, obviously dual antiplatelet is going to be more harmful in patients with thrombocytopenia. So you can take off at least one. Aspirin should be first one to go. Maybe I would extend that time to 1 month, because there are some trials of 1 month stopping dual antiplatelet, stopping aspirin, continue with other one. So that is fine. The question remains at what level you would go for thrombocytopenia and withdrawal. The thrombocytopenia itself has an antiplatelet effect. Those people, they do not clot enough. So lower the level of platelet, less the chances that stopping the antiplatelet is going to have any harmful thrombotic effects. So up to a platelet count of something like 50,000, I would not really bother about it to take it completely. But below 1 lakh, even if you take it off, you don't have a great risk of thrombosis because those people don't have platelets.
With that, I would like to thank sir for giving very detailed answers to so many doubts from our doctors. And also, there are so many appreciative comments and feedback for your session in the comment box. If you can just check it out, sir. And thank you once again, sir, for this wonderful session. Yet another wonderful session that you have delivered on Medflix. Really confident that our doctors really loved it. It's as usual, always a good time having you and hope to see you soon on Netflix. So thank you so much for this
Thank
wonderful
you very
session.
much. Thank you, everyone. Thank you, all attendees. And remember, Medflix platform is there. If you want to put in any question, comment, suggestion there, we would be there. And please share your ideas. What exactly would you like to hear? Thank you, everyone. Bye.
Thank you, sir. So, doctors, just like Sir said, you can still post your comments under the flyer on the Netflix app under the discussion, and also the replay of this session will be uploaded. You can watch it again and still post your questions under the flyer, and Sir will definitely get it answered. Thank you so much, doctors. And you can also post your feedback and your further suggestions. Thank you so much, doctors.
Thank you. Bye bye, everyone.
Thank you, sir. Thank you. Bye bye, sir.